the area, like in which quadrant and how much this diameter it involved, and macular involvement many will just mention about any macular edema present or not, or if any there are hard exudates near the macula. So, like how many is diameter away, or there is any center involving the diabetic macular edema, non-center involving. Those center involving and non-center involving are OCD classification. And the next slide, when you make the diagnosis, so just wanted to know, like right eye high risk and left eye you have not mentioned any risk, high risk. So why high risk and why not high risk in left eye?
In right eye there is minimal macular edema is present, so I think high risk, and also more hard exudate is present in the right eye.
What are the EPDRS criteria for the high risk? You give me.
There are three criteria. One is any NVD or any NV which is associated with retinal or intracerebral, and another is any NVD is greater than 1/3 or 1/4 of the size of the pupils, and any NV which is associated with more than 1/2 inch diameter size for the negative.
So that's why EPDRS is given this classification to define into high risk, and as Dr. Yogesh sir mentioned regarding the high risk criteria. So when we describe the neovascularization on the disc and elsewhere, also mention the like how much disc diameter, so we can get to know the risk whether it falls into the high risk or not. Because then our management changes, because we need to know that how urgent is the management, the patient regarding the patient counseling. That is where it is important. Yeah, go ahead.
On treatment basis and management, first we will systematic glycemic control will optimize the glycemic to target of HbA1c 7% is achievable. Individual rate or comorbidities, reviews and treat the hypertension and dyslipidemia. But patient was not on hypertension and dyslipidemia. Coordinate with the primary care and endocrinology for the medication and adjustment and lifestyle intervention. Firstly, if the patient is on diabetic or hyperglycemic, more hyperglycemic, first we have to control the diabetic and lifestyle modification is one key important. Ocular treatment, we have been anti-VEGF and vitrectomy is done. It is in severe cases, plan for, in this case, we will plan for the OCT and FFA, initiate with the pan-retinal photocoagulation, PRP for PDR, consider the intraretinal anti-VEGF therapy for the neovascularization or macular edema, and go for the anti-VEGF and after that PRP. Dr. Rahul, excellent presentation. I wanted to ask you that this is quite 35-year-old and he had history of diabetes since last 15 years. So, what are the important factors which can lead to rapid progression of diabetic retinopathy? One of them is poor glycemic control. So in addition to poor glycemic control, what are the other factors which are responsible for rapid progression of diabetic retinopathy? Dr. Nipun can also answer that. Dr. Nipun can add to it. Sir, firstly we have to control the diet, modification in that if the patient is more taking so high sugar, eating, so we have to control over it. Also, it can be very dangerous.
And other factors we have to check the renal status as well. the lipid profile as well. So, and hypertension as well. Hypertension along with diabetes will have a rapid progression. The renal factors, if it has a nephropathy, then nephropathy will have a higher progression, higher chances of progression. And hyperlipidemia also will have a higher chances of progression. Suppose if this, in females, what happens? The PDR in pregnancies also, the chances of rapid progression is there. So I wanted to ask you, like, pertaining to this case, how will you manage this case? Like, what are the ocular investigations and management treatment, and what are the systemic investigations would you advise?
So firstly, for the blood investigation, I will go for the CHbA1c in this patient, and also I will check the hypertension if it is hidden hypertension can be found in this patient, and also for the ocular examination, because I have done the exam examination, and I will go for the OCT. OCT, I will see if there is macular edema, and I will, in this patient there is no macular edema, so I will go for the anti-VEGF treatment, and for the hemorrhages also I will go for the PRP laser treatment. If the hemorrhage is not resolved, then I will go for the PRP treatment. If in 3 months if the hemorrhage is not resolved, then I will go for the different combinations.
So PRP is very important treatment in cases of PDR. So I would like to ask Dr. Nipun to explain some of the limitations of the PRP. What are the side effects sequelae of the PRP, especially in young patients? So Dr. Nipun, please explain the sequelae or limitations of the PRP, like poor night vision, something like that. Construction of the PRP.
So in young patients who are active drivers, so PRP, like extensive PRP, can lead to construction of the peripheral construction of the visual fields. In the nephropathy patients, we can have side effect as accelerated RDM, which has been reported post PRP. Also the epiretinal membrane formation.
This RP is accelerated RDM.
Yes. This is an accelerated RDM which will settle down in few days. Which will settle down on its own.
But we have to know about it.
Yeah, but we have to know about it, because in nephropathy patients, then we have to space the sittings in 3 to 4 seconds, because we have to minimize the number of spots to maximum 1000 per second. So we cannot use high energy and more number of spots in one setting to minimize the risk of accelerated RDM in nephropathy patients. And chances of ERM and epiretinal membrane formation, also reactionary macular edema. So when there is PDR and central involving diabetic macular edema, so the space between the anti-VEGF injection and the BRP should be less. Whenever possible, should be done under the cover of anti-VEGF, or on the same day you can do the first setting and can take the patient to the protein to inject the anti-VEGF, as we do on a day-to-day basis. So these are the risk factors.
So in the anti-VEGF, can you tell us some of the recent anti-VEGF which are in pipeline, which can help in these cases to restore or to decrease the macular edema and to decrease the neovascularization? What are the recent advances going on in the field of anti-VEGF?
So the recent advances which are going on the field of anti-VEGF are Proliferative which has come, which has a strong bright effect. Then Fanacimab, which has the action on ANG2 receptors also, angiopoietin 2 receptor also, and this aflibercept high dose is coming, which is 8 mg as compared to the conventional 2 mg, which is a VEGF trap, which acts on all the VEGF and even the mesenchymal growth factor and the galectin receptor. And this one more is in the pipeline, which is called Ophthalmology, which is sosniferaset, which is the trials are going on. So which is also a new anti-VEGF, sosniferaset, which will help in evaluating the diabetic retinopathy